earlier today is how do we assess adherence? How do we measure it? And Karen's going to be diving into this a lot further in her presentation. So Karen is the Charles R. Walgreen III Professor of Pharmacy Administration at the University of Michigan College of Pharmacy. Her research and teaching focus on social theories in medication self-management and the role of the pharmacist in influencing medication behavior. So Karen, thank you very much for coming all this way to present, and there'll be time for question and answer after her presentation as well.
So, it's late. Just want y'all to know it's 5:30 at home. I woke up about 3 o'clock this morning here. I'm getting a little sleepy, so thankfully I'm up here talking to you, so I'll stay awake. All right, so my first few slides are really reiterating what you've heard today, and I'm really going to go through them pretty quickly, okay? And then we're going to get to 3 different ways that you can assess medication adherence in your practice. I'm not kidding. I'm not kidding. You really can do it, okay? And then I'm going to share with you the follow-up question to that assessment that you also must ask, okay? And then I'm going to give you those examples, and then I'm going to give you just a little bit of data because, you know, I'm one of those geeks that loves the data. And then I'll have a few parting words, okay? All right, so let's go on this journey. Here we go. All right, I do have a couple of disclosures. I've submitted an SBIR grant with a company called AHRQ Reminder. So that's a company in Ohio that's looking at some electronic ways to improve medication adherence. So just FYI. And then we're using some MEMS caps in some research that we're working on. So just, I'm not making money on them, but I just felt like I needed to tell you what's going on. All right, so here's what I'm going to do today. And like any good academic, I have to have a lowly model. So what this really tells you is that from the group that I work with, the researchers that I work with, we think about capacity of the individual, are the meds available, does the person want to take the meds, and can they remember to take their meds, as the primary issues around first taking their meds. Okay, so starting to take their meds and be adherent to them. But then, what happens with the meds in terms of positive outcomes or negative outcomes also reinforces whether they continue to take those medications. So the way we think about persistence may need to be a little different than the way we think about initial adherence. And I think you've heard that this morning. Okay, so I'm not telling you anything new. I just have a lovely picture with boxes. Okay. All right, because you're not an academic, that's what we have to have. Okay, you've also heard all of this very quickly. Medication non-adherence is prevalent. It leads to poorer outcomes. There are actually a few nice meta-analyses that are linking non-adherence to clinical outcomes. So if you're interested, I could get you those. It also leads to higher costs. Medication non-adherence is often a decision. It is often a decision, and I'll show you some data to support that. And we have talked about it's caused by a gazillion reasons. And I'll show you data on that as well. This is important. The same individual can be adherent to one medication and non-adherent to another. Historically in the literature, you think about and you read about this patient's non-adherent. And you're adherent, we like you. And oh, you're non-adherent, oh, we got to work on it. Okay? So that's not the way it is. That's not the way it is, and the data tell us that. Okay? I might want to take my meds for my heart, and I hate my meds for my arthritis, or vice versa. Okay? And there's data to support it. I don't have it with me today, but I can get it for you. You need it. Okay? And then, of course, non-adherence is like the cool, sexy thing now to study. It's like, yeah, I'm back, you know? So it's exciting. All right. So fiction. There is a non-adherent persona or personality. I kind of told you that already. Right? You're not a single person. I'm this non-adherent person. That's not the way it is. Okay? People should just do what their doctors say. They should. So, you know, I work in a and we had students up here talking about, that patients are non-adherent. But you will talk to first-year students, and they're like, people will take their meds if you tell them to. I'm like, what planet are you living on? Do you do everything your mother says? And they're like, no. I'm like, all right then. So people don't just do what their doctors say. And it's not for malicious reasons. It's for a lot of other reasons, okay? You've heard that. It's only about whether people can afford their medicines. That's an important reason. Probably 1 in 5 cases of non-adherence are attributable to cost. But that leaves a whole lot of other reasons that are important. And then fiction. We know how to improve medication non-adherence. I think we kind of do. Like when I'm dancing like that. I think we kind of know how to do it. What is important is that you know the reason and you try to match the intervention to the reason, and you've heard that already today. Okay? I do think, and this just came out this year, I was walking around and I about fell over because I was reading it on my phone. So if you think about all the medication non-adherence studies that are out there, a recent, I think they were out of McMaster, they're talking about how people in studies of non-adherence are actually adherent. So, if we're recruiting mostly adherent people into our studies to test interventions, it ain't going to get any better because they're already doing pretty well. Now, you go out there and you try to recruit non-adherent patients to a study. Because, honey, I'm trying to do it and it ain't working. It's not working very well. I'm afraid AHRQ is going to come get me. Like, you go recruit non-adherent patients to your study, to your randomized trial even. And so, I think we're in this really tough place when we say adherence interventions don't work. I get that, but I'm not sure we've been in the right population, and I'm not sure we can get them. I don't know. It's kind of scary. All right, I got to keep going. Okay, I'm really going to buzz through the next 3 slides. You've certainly heard this today. There are direct measures of non-adherence. Let's get a blood level. Let's see if the person's taking their drug. There are indirect measures of medication non-adherence, and there's a gazillion of them. And you've also heard there is no single correct, right measure. So get over it. There's not a single way to do it. There's not only one valid way to do it. It's tough. Okay? So what I will tell you, though, is that here's the feature. So someone talked about putting the electronic chip in the drug. That's coming, but that actually scares me a little bit. That's even more big brother than these are. Okay, so these are kind of big brother. We know if you're taking your drug. We can monitor it. I'm doing a study where we're testing that technology. So it's nice to know if someone's taking their meds, but it's kind of a big brother thing, right? So, we'll see. But there's lots out there. And it's going to get more. And it's going to get cheaper so that we can dispense it right out of pharmacies. Okay, that's where we're headed. Okay, that's my overview. What can you really do in practice? Well, you could do like a 30-minute interview, right? Every one of you can do that, right? Right? Yeah, you're like, Karen, you're in La La Land. You're from Michigan. You are in La La Land. All right, so what is practical? Well, if the drug is amenable, do a drug level, okay? There's a few that are. If you have refill records, that gives you a great indication. Kaiser, they are mining the data, not in a bad way, in a positive way, calculating PDCs, looking at records to see if they're taking their meds. If they're not taking their meds, I bet they're getting on the phone. I bet they're sending them a message. I bet they're contacting them about their meds. Because if I was them, that's what I do. Right?
Yes.
Maybe not yet.
3 sources for that.
Okay.
So it's more in the office or
Okay.
phone or face-to-face.
Yeah, we should get there on a population level.
Yes.
Yeah, okay, anyway. All right, so if you've got refill records, that's your first indication. If you don't have refill records, you're going to have to ask. I don't know any other way around it. You're going to have to ask. So, you can't spend 30 minutes doing it. You can do a pill count. Number one, most people don't bring all their meds in. They may or may not. That takes a long time. There is a nice study from 13 or 14 about a telephonic pill count. Very cool. If you want that, I can get it for you. It's a nice protocol. It takes about 20 minutes to do. So that's a long time in day-to-day practice. But it's a cool technique if you have the time. And then electronic monitoring that I was just talking about. And still, that's just costly right now. But still a nice technology. So, I got 2 things for you to definitely think about, and one is an FYI, because I think it takes too long. All right? So, number 1, single item, past 7 days. I'm going to show it to you in 1 second. Single item rating scale. And you're going to go, Karen Ferris, I don't like that. Because everybody in here wants a number. I know you do. You want a number. Okay? We're going to talk about why I think the single item rating scale is our best day-to-day assessment of medication adherence. I'm going to show you the draw tool. It's a tool that I worked on with some folks at the University of Iowa. And it's a nice tool. It includes 8 or 9 reasons for medication non-adherence, but it takes some time. So I'm going to show it to you, but I'm not going to spend a lot of time on it. Okay, here you go. Not rocket science. Over the last 7 days, how many days were you able to take your heart medicines as prescribed? Your arthritis medicines as prescribed? Your blood pressure medicines as prescribed? Why am I telling you to ask a class? Because people think about those drugs differently, remember? We said that. I'll be non-adherent to my heart med. I don't want to take my arthritis meds, or whatever. Ask about a class. Should you ask about each medicine? You ain't got time. You ain't got time. So don't do it. I know you don't have time. Okay? But you need to think about asking about classes of meds. Okay? I'm going to show you some data on this question in just a little bit. Here's a single item rating scale. Thinking about the past 4 weeks, please rate your ability to take your heart failure medicines as prescribed. How to take your blood pressure. Rate your ability to take your blood pressure medications as prescribed. Excellent, very good, good, fair, poor. Y'all are like, Karen, I don't like that. I want a number. I want a number. I want 4 days, 2 days. Folks, this is the good one right here. I'm going to show you some data. This is the good one. I'm not kidding. I love it. It's what we're using. Even though my tool. So this is the one that I've been working on with one of my graduate students, my former graduate students. So this is Elizabeth Uni. And so that's our question. But after doing more work, this is the better question. So it's the one I'm using now. All right, so this is the one I'm recommending, and I really am strongly recommending it, as you can tell. Okay, this is the draw tool, the drug adherence workup tool, and it is asking 9 questions that you would use to interact with a patient about. Please tell me how you take your meds every day. Do you feel you're taking too many? Do you sometimes forget on routine days? And do you sometimes forget on the weekends or non-routine days? We know that's what the data tell us. Weekends just mess everybody up on their meds. Right? Because you don't get up, you're not going to work, you're not doing your normal thing. Okay, so non-routine days can be an issue for non-adherence. Do you have a concern that the medications are not helping you? You can read the rest of those. What is positive about this tool is that on the back, we link different strategies with these different reasons, different intervention strategies with these different reasons. So I'm happy to share this with you. I can give it to Rebecca and they can post it or link to it if they would like to do that. Okay, this is the important follow-up question, folks. So you ask the person, in the past month, how would you rate your ability to take your blood pressure medicines? And they say, oh, I was very good. I'm going to show you some data in just a little bit that says, oh, that means they're not perfect. Okay? So this is your next question. We know there are many reasons why people don't take their meds. In thinking about your blood pressure meds, check all the reasons that caused you to miss them in the past 4 weeks. Check, check, check. This guides you to an intervention. These reasons guide you to an intervention. So we've got, if I can get the pointer to work or not, there it is, side effects. You've had side effects versus concern about side effects or concern about long-term effects. Okay, so I've either experienced one or I'm like, dang, I don't want that to happen and I'm so concerned about it. Okay, we know concern beliefs are related to non-adherence. I don't think I need it anymore. I don't think it's working for me. So why in the world is somebody going to take a medicine if they don't think they need it? They're not. Okay, you might think they need it. Right? And you as a pharmacist might think they need it. But you got to talk to them about whether they think they need it or not. And that would be a motivational interviewing approach for that conversation, as well as perhaps the concern beliefs. Okay, you're going to have a motivational interviewing discussion. Whereas if someone's had a side effect, you're going to try and figure out, is the dose correct? Do we need a different drug? Do we need to treat the side effect? Okay, because maybe they still need that drug, but we need to treat the side effect. So you can see right there, different strategies for different reasons. I'm not telling you anything you don't know, but we have to make it real in practice. We have to make it doable in practice. I don't have money to pay for it. Okay, so we're going to have to work with our social workers. We're going to have to work with pharmaceutical access companies. We're going to have to work with $4 programs. We're going to have to work with our insurers. I don't know what we're going to have to do. Okay, any and all of that. Okay, the pharmacy didn't have it. So I'm working with Oral Oncolytics, the group of the Michigan Oncology Quality Consortium, and we're working in our oral oncology program. And so we know that individuals have delays in getting their oral oncolytics. Can't even hardly say it, oral oncolytics. And so sometimes they may be delayed 3 or 4 weeks before they can get that medication, but the doctor thinks they've started it because they wrote the prescription. So delays, shortages, we heard that earlier today. So then these next questions, I'm having trouble managing all the meds I take. That should be taking. I have trouble taking it because of how and when I take it. I missed it because I'm busy. I have trouble forgetting things in my daily life. I just missed it. So you're like, that's a lot of reasons around, whoa. So we're trying to understand forgetting. People report a lot of forgetting on Morrisky. There's a lot of forgetting going on, folks. But yet we need to more fully understand Morrisky. Okay? All right. So that's my point right here. We didn't ask specifically about forgetting, but we asked these different ways to do it. So, real quickly, I've got some data for you. The more reasons you ask about, the more non-adherence you're going to find, generally speaking. So if you ask about 16 reasons, you're going to get people checking more of those things, and you're going to go, oh, there's more going on here. Okay? And so that's generally what these data show. Yes?
They didn't have the option to say, I never missed it. They needed to check one day. So
No, they could say they didn't miss. They could say,
okay.
so actually on these data right here, this right here, non-adherent using reasons, it was actually collected using the 0 to 7 scale, so they could put 0.
Okay.
0 days for this reason. Okay? But the point still is, if you're going to ask a bunch of reasons, you're going to get more non-adherence. Okay? I'm going to keep going. This is data from our aromatase inhibitor survey that we recently completed. And this is your excellent, very good, good, fair, poor question. 82% of people are excellent, which is excellent. 18% of people are not. I'm going to keep going. This is our oral oncolytic data. 74% of people are excellent, so way fewer. 25% of people are not excellent. And you're like, okay, so what, Karen Ferris? Here's the so what, folks. So I have to get my notes out so I make sure I tell you exactly what these folks did. So the reason I'm really promoting, and I am promoting this measure, it's true. I don't even know this investigator. I actually wrote a note. Email Lou and Phil, but I actually wrote that to myself because I need to get on board with them, and we need to get this out to everybody. Okay, that's another story. But so what these data are, this is MEMS CAPS openings, MEMS CAP adherence. So, you know, if you're writing a grant to NIH, that's like the only way you're going to get funded if you got an electronic measure. Seriously. And so it's our best sense of whether a person is taking a drug day to day, besides the drug level. Okay? But we can't study every drug with the drug level. So the person opens the cap, it gets recorded. Do they take it? I know there's a problem with it. I get it. They can be faking it. I get it. Okay? But what these data show is that among these 100 and some odd people, when you ask them to self-rate over the past month, this is the line that they drew that shows the correlation with their MEMS CAPS opening. That's a pretty nice line, folks. That's a pretty nice line. What you also need to know is that they also used as a response scale in the past 3 days, in the past 7 days, in addition to excellent, very good, good, fair, poor, they used the frequency of time and they used the percent of time. And the reason that they really landed on this one is because there's less over-reporting. And everyone says the problem with self-report is that people over-report how great they are. And they do, I get that. They do, I get that. So when someone says they're very good, that's like 75% adherent. That should still be a clue that you should ask some more questions. That's my point. Okay, these are pretty good data. Then in 2013, oh, that's supposed to be a paren right there. That's supposed to be a paren. So in 2013, a follow-up to this study, also using the excellent, very good, good, fair, poor in the past 4 weeks, was compared to a visual analog scale the past 4 days. Did you miss over the weekend? And again, this response scale was the best. Okay? All right. I have 2 more slides. So this is all the reasons that we posed to people who were taking their asthma maintenance medications. And this is the list of reasons when people had adherence less than 90. Don't write these numbers down. Don't even, you don't have to read it. What I want you to do is look at the number of reasons for asthma meds. Same data for cholesterol lowering meds. Different reasons, different meds. Ask about different classes of meds. Here's additional data for not taking for aromatase inhibitors, and clearly side effects is a big one. And then this one is just, they just simply missed it. So we're still looking at these data. These are very early data, and I can't talk a whole lot about them. These are data from our draw, so I'm going to keep going. All right, I have 10 seconds left, and I'm there. Medication non-adherence. Maybe it's not more prevalent than you think, but it's definitely out there. It's clearly even among 20, 30% of our patients who are taking chronic meds. The literature says 50. You know, I'll be honest, I don't know if it's that high or not. 20 to 30 for sure. Importantly, different reasons for different meds. That is important. Different, therefore, reasons give you different interventions. So you may need an intervention for someone's blood pressure meds that looks different than their intervention for their arthritis meds. So this ain't easy, but we gotta try. So my recommendation, use a single item rating scale, use your refill records, or a clinical indicator to gain insight, then follow up and ask about reasons. Ta-da!